nice to see everyone here, and it's nice to see all of the interest for women's health in epilepsy. So my job today is to talk about several topics. And so, no talk about pregnancy would be complete without talking about how not to get pregnant. We're going to talk about options for contraception. We're going to talk about patterns of seizures that may change during the hormonal influences of pregnancy. We're going to speak a bit about how epilepsy affects the pregnancy, and of course how pregnancy affects your epilepsy. Everyone wants to have a healthy child, and we're going to talk about the risk of having a child with a birth defect, learning disability, or autism. And that's actually a changing world, and I'm happy to say that there's new information each time I update these slides, which is fantastic. We're going to talk about ways to improve your health while you're planning for pregnancy, and I hope some of you in the audience are planning for pregnancy. We're going to speak about breastfeeding, and then we're going to end on not an especially cheery note, but we're going to talk about postpartum depression. So some of our medications to treat epilepsy will interact with birth control pills and actually make them less effective. And the reason that they do this is that they affect the liver. So they're metabolized by a particular enzyme in the liver in a system called the P450 system. That P450 system metabolizes a lot of things. And so some of you are on medications like Tegretol or Dilantin, phenobarbital, that actually rev up that P450 system. So even though many of you are worried about your liver, truth is your livers are very good. They are metabolizing things faster than other people. So when they do that, they metabolize anything else faster. So if you are on a low-dose birth control pill and you're on Tegretol, your P450 system is revved up. So you will metabolize that low-dose estrogen and progesterone faster than other people, making that birth control less effective. So this is true for any of the medications that are metabolized through the P450 system, with the exception actually of Depakote. Depakote is a P450 inhibitor. It shuts it down. So Depakote interacts with other medications through that, and there's a reason why some other drugs are higher if you're actually taking Depakote. So for many women, you can still take an oral contraceptive pill if you're on one of those P450 drugs, but you need a higher dose pill. So 20 years ago, most pills had 50 micrograms of estrogen in them. 10 years ago, they were 35 micrograms. Now they're 20 micrograms or 15. So if you're on a medication like Tegretol and you're metabolizing that 15 microgram pill faster, then that's not going to be an effective form of birth control. So you can still take it, but you need more estrogen and probably more progesterone. Now I'll warn you that most neurologists and gynecologists are not familiar with these issues. And so you do need to bring it to their attention. And many people who are not in the epilepsy world, even if they know there's an issue, they don't understand that it's a complicated issue. So for example, it's not a problem with medications that don't affect that P450 system. So sometimes you're getting incorrect advice. So you really do have to stay on top of this. The good news is there are other options for birth control. So here are a list of the medications that will reduce the effectiveness of the pill. Does everybody have a handout? If you don't have a handout, there are handouts, so you don't have to take notes on this. And here are the medications that don't affect the pill. So the reason Depakote does, and once again, that's the one that shuts down that P450 system, and then some simply don't go through the liver. That's why some of you are taking Keppra or levetiracetam. It's a nice drug. It doesn't go through the liver, makes life a little bit easier. And so here's a list of those drugs. Now Depo-Provera, that's an intramuscular injection of progesterone, but it's a synthetic progesterone. And some progesterones can help seizures. Dr. Jacobson talked about that a bit. Those are more the natural progesterones. The synthetic ones may not be very helpful. Depo-Provera can be a good choice of birth control for people who remember taking their pills. Another issue with the lower dose estrogen pills is you have to be right on top of what time you take them. And so there is a failure rate. If you even forget your dose by a few hours, then that low dose hormonal pill may no longer be effective. Many women who take Depo-Provera will get a shot every 10 weeks instead of every 14 weeks, to also allow them to have a higher dose of progesterone. Depo-Provera, however, can cause osteoporosis or thinning of your bones, and we learned from Dr. Schmidt how that's also a very important topic for all of us. IUDs, far and away the most popular choice now for women with epilepsy, although I have, it was interesting for me to see Dr. Jacobson's slide with the less than 1% failure rate. My heart was broken when one of my patients was pregnant after her first year of college. She's a very responsible patient, on carbatrol, seizure-free, sexually active. We had the discussion. She got an IUD, came home from her first year of school thinking she had mono, and actually she didn't have mono, she was pregnant. So there are failure rates. Sometimes actually the IUDs are difficult to insert in women who have not had a prior pregnancy. So, and then women who are sexually inexperienced. She didn't realize that something was wrong. Her partner, also sexually inexperienced, didn't realize that he shouldn't be able to feel the IUD. And so they unfortunately had that issue to deal with. So there are several IUDs. There's the Mirena. That has been a very popular choice. It secretes low-dose progesterone locally in the uterus. So for women, it gives you a lighter period, which is great. It's active for 5 years. It does not have prolonged effects on fertility. So you could have it taken out on a Tuesday and get pregnant on a Wednesday. That's very nice. There's the Skylar, which is a 3-year IUD. It's a little bit smaller. It's easier to insert in women who have not had a previous pregnancy. And that also secretes progesterone. There's the copper IUD. That one's effective for 10 years. It does not secrete any hormones for people that might not want that hormone exposure. And of course, 10 years is great. And it is effective with all of our anti-epileptic medications. Now, unfortunately, the woman left who was asking this question, but the flip side is also important. Birth control pills can also affect the levels of your seizure medication. And this is also something that a lot of people, a lot of doctors actually are not familiar with. This is especially important for Lamictal, but it also happens with Depakote. Now, during the active pill weeks of estrogen and progesterone, your Lamictal levels can drop by 50%. That's a huge drop, right? You wouldn't go get a generic medication that's fluctuating by 50%. Well, that's what's happening when you're on a birth control pill. During the placebo week, right before bleeding, your levels can increase by as much as 80%. That potentially could help women who had catamenial epilepsy. They're going to have a higher dose of medication rate at that time that they're going to have a risk for seizures. But the fluctuation really can make people lose control of their seizures. So I have many women who come in to see me and they are on Lamictal, they're started on a birth control pill, suddenly they think Lamictal's not working. Well, the reason it's not working is they're not having adequate levels. Often, simply stopping that birth control pill will allow women to get back to being seizure-free. There is a registry, and anyone is invited to participate in this. This is from Andy Herzog and a lot of other investigators. They're trying to get a little bit more information about what women are using for birth control and what's effective, what's not effective. And if you have a couple of minutes, you can go on and take their survey. Let's switch over to issues regarding pregnancy. So we have a basic dilemma, and that is generally for women who are pregnant, they don't want to be taking any medications. Many medications most medicines have to be used with caution for women during pregnancy. But of course, women with epilepsy cannot generally stop their medication. They need to be on these life-sustaining medications. Medications or seizures can result in injury or even death in the mother or the child. And of course, seizures can also lead to loss of job and driving privileges. One of my least favorite things to do is report someone to the Department of Motor Vehicles. Unfortunately, I do it a lot. One of my favorite patients tells me he curses me every time he walks through his garage and he sees his car there that he cannot drive. But I can handle that. Now, if you are planning a pregnancy or if you are pregnant and you have epilepsy, you should know that you are not alone. Women with epilepsy account for 1 in 200 pregnancies in the United States, which means that more than 25,000 children are born to mothers with epilepsy each year, a staggering number. You are not alone. Your seizures can change during pregnancy. And I know this isn't a terribly helpful slide, but about 50% of women will have no change in the pattern of their seizures. 25% will actually have fewer seizures while they're pregnant. 25% will have more. Generally, if you're going to have more seizures during pregnancy, that pattern becomes evident by the end of the first trimester or the beginning of the second trimester. And what happens in one pregnancy is not supposed to predict what happens in others, but I have been doing this for long enough and gotten many women through pregnancies, and it actually does seem to be predictive. So I'm a little more comfortable in women who have been seizure-free in one pregnancy, and a little more cautious in women who have had a difficult first pregnancy. Now, the effect of the pregnancy on the seizures, of course, seizure control during pregnancy is critical, and our goal is to remain seizure-free. The death rate during pregnancy is increased tenfold for women with epilepsy compared to the general population. Pregnancy is not a benign condition, and this increased risk for women with epilepsy is primarily due to seizures. Women that are seizure-free for 1 year before conception are those that are very likely to do well through the pregnancy. Now, why do women have more seizures during pregnancy? Well, some women stop taking their medications. Don't do that. That's a bad thing. So many women recognize that medications can cause harm to the fetus. They don't also recognize that the seizures can cause harm, of course, to their fetus too. Many women are sleep deprived. We heard, of course, in the lifestyles talk that sleep deprivation is a trigger for seizures. And then the biological factors, the hormones that Dr. Jacobson talked about. Medication levels change a lot when you're pregnant. We're going to talk about the importance of having levels checked. Medications during pregnancy may not be well absorbed. A lot of women, when they're pregnant, have lots of gastrointestinal distress. And part of that then affects how you're absorbing medicine through the stomach and through the gut. So your levels may change just because you're not absorbing your pills the same. Your liver may change. It may affect how you are metabolizing your medications. The kidneys may eliminate the medication more quickly. Plus, you've gained weight, so that may affect your levels as well. Now, most medicines will change during pregnancy. Not all, but most. But we know that some will change more than others. Dilantin and Tegretol tend to drop later in the pregnancy, especially in the third trimester. Depakote's tricky. If you're on Depakote, you need not just a total level, but a free level. Now, most people aren't familiar with the concept of what's a free level. So a free level of medication is what's not bound to proteins and what is just floating around in your blood freely. That's actually the active part of the medication. Your protein levels change when you're pregnant. So for Depakote, often the total level declines, but the free level will stay the same. So for Depakote, you may not need an increase in your dose because your free level, which is the active level, actually may stay the same, so may not require a dose increase. Some medications change a lot, especially Lamictal and Keppra. I know when a woman is on Lamictal or Keppra and gets pregnant that she and I will be having lots of communication through over the next 9 months. Patient portal has been actually a huge advantage in my practice because with the patient portal, I can communicate with people, and I know that I'm getting back to them promptly. I'm seeing levels promptly, and we're staying on top of this. Now, how often should you get your level checked? You can speak with your provider, but I suggest once a month. And I know that's a lot, but truthfully, sometimes I do it more than that. For women who are constantly having their doses changed every month, well, I want to stay on top of it, so then sometimes people have to have it done every 3 weeks or even every couple of weeks. Have your blood drawn in the same lab under the same conditions. So make sure it should generally be a trough level. So in the morning, before you've taken your morning dose, try to make sure that the dose from the night before was the same, because what we're doing is comparing levels from like 1 month to the next, and we want all of the conditions to be the same. So if you go to a different lab and let's say you're on Lamictal and the first time you had it drawn, you didn't take your dose, and then the second time you did, those are going to affect the results of your blood work. So keep everything the same. And then, don't assume your doctor has seen your blood work. If you don't hear from them within, a week, you should be contacting them and say, I had my level done, what was it, and do we need to make a change in the dose? There is a twofold increased risk of all pregnancy complications for women with epilepsy, and that includes preeclampsia, which is getting into trouble with high blood pressure, early delivery, ruptured placentas, excessive vomiting, and then bleeding at delivery. There is, however, no need to have a cesarean section unless you have a brain reason to have that, such as a vascular malformation in the brain, where you'd want to avoid any increased pressure during labor and delivery. Now, of course, one of the most important questions, and that is, what is the risk of having a child with a birth defect for women with epilepsy? I always tell every woman as they're planning a pregnancy, no one's guaranteed a healthy child in life. And the risk of having a child with a major birth defect in the general healthy population is running about 2 to 3%. So no one is guaranteed a healthy child. Generally, the risk of major birth defects for women with epilepsy is about a twofold increased risk. Now, we actually know a lot more about individual risks from individual drugs, but in general, it's about a twofold increased risk. So what that translates to really is that most women have routine pregnancies and deliver healthy babies. General rules about birth defects: using one medication is safer than using 2. And of course, that just makes sense. Generally, though, women who are on 2 drugs perhaps have more difficulty to control epilepsy, and that may also play a role in outcomes. Higher doses of medications are worse than lower dose, and that's critically important, and we're beginning to get a lot more research into doses. It's not a good idea to switch medications while pregnant. This requires planning, and if you're going to get pregnant, if there's even a chance, make sure you're on the right drug before that happens. If you come in and, so at least once a year I have someone coming in to see me who's on Depakote and has heard that Depakote's not a good choice during pregnancy, and they're 6 months pregnant and now they want to change their medication, it's too late. And also, you wouldn't want to expose the fetus to 2 drugs. So you need to do this before conception. There are many individual differences with all the medications, and we'll be talking a little bit about that, but we are still trying to figure it all out. Any birth defect can be seen with any organ system, but cleft lip and cleft palate, cardiac defects, and neural tube defects, which is spina bifida, are what's seen most commonly. The neural tube is very interesting. So, a fetus develops from a single cell, and this is our brain development. So, as we get, our brain develops from a plate. That plate expands, and then it closes, kind of like a garden hose, and it has to. It closes basically like a zipper. So that makes sense then when you think about certain defects, right? Cleft lip and cleft palate are failure of the closure at the mouth. The neural tube defect is failure of the closure at the spine. And so that happens very early in the pregnancy, often before women even know that they're pregnant. So that happens 27 days after conception. So right about the time that you realize, I don't seem to be getting a period. So the problem is that you need to have everything planned beforehand because after this time it's too late. The neural tube has either closed or it has not closed. The risk of having a child with a neural tube defect in the healthy population is 1 in 1,000. The risk, however, with Tegretol is 1 in 100. And the risk with Depakote is higher. It's 1.5 to 2%. What we know is that folic acid will reduce the risk of neural tube defects in the general population. And it seems to also be in women with epilepsy. It helps that zipper close. The required dose is unclear, but at least 0.4 milligrams, which is what's in most multivitamins, up to 5 milligrams. There is also evidence from the NEED study, which we're going to talk about, which shows that women who are taking folic acid before conception have smarter children. And IQ points are 6 to 8 points higher in children of moms who are taking folic acid. However, many women who have epilepsy don't take folic acid before conception, and many studies have shown that doctors don't even tell women to do it. And if you are considering getting pregnant, you need to start taking folic acid. And I am ashamed to say that in our NEED study, where we found this very striking result that was done in centers that were in great institutions with people very interested in women's health, only 40% of women were taking folic acid before they conceived. So we definitely need to do a better job of having people take folic acid. Now this is probably the scariest slide that I have that worries me a lot, and I don't know that if you're familiar, but the FDA has categories of medication during pregnancy. And the categories start with the letter A, and then the next letter is B. You can see we don't have any A's or B's. A's and B's are drugs that are acceptable in women in general as they're planning a pregnancy. All of our anti-epileptic drugs are either a category C or a category D drug, meaning that they can pose harm to a fetus. Now we are getting a lot of information about pregnancy and epilepsy from pregnancy registries. About 10 years ago, everybody started a registry, which was nice, but it also made life very complicated because different registries were reporting different information. But I'm going to show you a little bit of information from the North American Anti-Epileptic Drug Pregnancy Registry. I think it's a good idea to look at the registries that are in your own country. There are cultural differences with treatment and also, though, with risk of birth defects. So for the North American Pregnancy Registry, you can see we're beginning to get pretty good numbers of women enrolling. So these are women who are calling in, they have epilepsy, and they are prospectively reporting that they are pregnant, and then the registry is finding out what the outcomes are. So you can see for lamotrigine, about 1,800 reports, and the risk of birth defects is only 2%. Well, you'll remember I just told you a little while ago that the risk in the general population is 2 to 3%. So that's a really good number. Some people feel that perhaps there might be some bias in some of this reporting. The women themselves are calling in to report that they're pregnant, so these may already be women who are highly educated and are finding these registries to participate in them. But that is a reassuring number. Now, up until this year, lamotrigine was the #1 prescribed medication for women with epilepsy planning a pregnancy. This is the first year now that levetiracetam or Keppra is now #1 and lamotrigine is now #2. Now we all want to know about our children and their cognitive outcomes. Children of women with epilepsy may be at a higher risk for impaired cognitive health. That disability has been associated with maternal seizures, and we have some information that perhaps 5 or more generalized tonic-clonic seizures seems to be very concerning regarding cognitive health. but also your children's IQ is based on your IQ. So for women who are higher IQ, they should have a higher IQ child. Now, there aren't a lot of men in the audience, there are a few, but the men should know that their children's IQ is actually based on their partner's IQ. So children's IQ links with mom's IQ, not dad's IQ. So if you have a smart child and you're the mom, you should be very proud of that.
It's not so smart.
Now we're gonna. I mentioned this a little bit earlier. This is the NEED study, which I had the privilege of participating in. It was an NIH study looking at the cognitive health of children born to mothers with epilepsy. So we had women with epilepsy, and we had fetal consent forms for the fetus to participate in the study. We also had mom sign, their partner, and a first-degree relative. And we enrolled women who were taking either Dilantin, Tegretol, Depakote, or Lamictal, and we looked at the cognitive health of their children. The NIH required that we did not enroll women who had epilepsy but were not taking medication. I think that was a mistake from the NIH. We should have probably had a group of women not on drug, but what they didn't want to be a conclusion at the outcome of the study that women should stop their drugs. So they decided not to include that as a test arm. There are many results available for the NEED study, but this is the one I think that drives home the point. And this is the chance of having a child with an IQ less than 70, and that makes a big impact on life. So the chance is with Tegretol 3%, with Lamictal 2%, with Dilantin 5%, and with Depakote 13%. That's a big number. And the lower IQ was linked with younger maternal age. That some people may be surprised by that. The absence of using any folic acid, low socioeconomic status, which of course impacts nutrition and access to health care, and then also dose of medication. Depakote children, the mean adjusted IQ was 9.7, so almost 10 points lower for women, for the children of moms who were on Depakote more than 800 milligrams a day. However, if you're on less than 800 milligrams, there was not an impact on IQ, but there was reduction of verbal ability, and also an 8-fold increased need for educational intervention. Now, autism, we're beginning to learn a little bit more about autism. There's a 4-fold increased risk for autism and autism spectrum disorder in children of women with epilepsy, 6% versus 1.5%. And once again, the highest risk seems to be children who were exposed in utero to Depakote. The best medication to use during your pregnancy is the one that controls your seizures, but in the lowest dose. So I've told you some scary things about Depakote, but I have a lot of women who have had pregnancies and delivered healthy children on Depakote. There are some women that Depakote is the only drug that controls their seizures. And so we do target getting on the lowest dose possible. We know that phenobarbital also has a very high risk for birth defects, and luckily, many of the doctors who used to prescribe phenobarbital aren't doing that anymore. I'll never forget Marty Morrell, who did a fellowship where I was, and has always sort of been an inspiration for women's health and epilepsy, used to say that any of the doctors that were prescribing phenobarbital for young women that were planning a pregnancy, they all should just die. and so it really is, it's very dramatic, but certainly it makes a good point. It makes a very good point. Depakote, of course, has also a high risk of birth defects and decreased IQ, but once again, dose is important. If you're a woman and you're controlled, you're on Depakote 500 milligrams a day, that may not be a bad choice. We know that Lamictal and Topamax have a higher risk of cleft lip and cleft palate, but also we know all medications must be used with caution. A year ago, there was a report that Tylenol should not be used during pregnancy because of an increased risk of birth defects. You wonder what you can do right when you are pregnant. Now, are seizures during pregnancy harmful to the fetus? Perhaps. Seizures during pregnancy have been linked with fetal death, also bleeding into major organs, which were brain, kidneys, heart, and skin. And there is a higher rate of learning disabilities, as we said. Seizures also can lead to direct physical trauma to the abdomen, which can cause harm to the fetus. But not all seizures are linked with poor outcome. I have had women who have had very difficult pregnancies with poor seizure control, and I hold my breath when they tell me what happens with their deliveries and their children, and you cannot always predict what is going to happen. People often want to know what's the risk for epilepsy in their children. Dr. Sperling spoke about this a bit. Certain types of epilepsies can run in families. The risk of epilepsy in children of people with epilepsy is generally 5 to 10%. Talk to your neurologist or even a genetic counselor. Many people are shocked when they find out there's a genetic test for their disease, and it's not too difficult to get. There's a laboratory company called the Prenatal Laboratories, and they have panels for genetic screens for epilepsy. Sometimes it's expensive, but they often will tell you in advance how much it will cost you to have a genetic test run. Now let's talk about what you can do specifically. So before pregnancy, I hope you understand now that you must discuss family planning early with your doctor. Your doctor will try to minimize your medication whenever possible. So, I'm guilty of this, as I'm sure many doctors are. You have a woman who has had a difficult struggle getting her seizures controlled, and finally she's controlled, and maybe she's on 2 drugs, but you don't really know for sure if she needs 2 drugs, or she's on 1 drug, but a high dose. The question is, could you eliminate 1 drug? Could you go lower with the dose? And it's worthwhile investigating that before pregnancy. Everybody should know what their anti-epileptic medication levels should be during pregnancy. Truthfully, as doctors, we don't really know, but I do like to have a range. I like to tell people, okay, I want your Lamictal level to be between 4 and 8. So if I make a mistake and there's a blood level that comes back and it's 3.8, tell me. That's not in my range. So everybody should know what their blood level should be. Of course, take your medication. Take the prenatal vitamin, take folic acid, and the usual, exercise, eat well, sleep well, and do not smoke. During pregnancy, have your blood levels checked routinely. Continue taking your vitamins and your folic acid. Many people are followed by high-risk obstetricians. Everybody gets a million ultrasounds. There used to be recommendations about when to get them, but people get a lot of them. There is the anti-epileptic drug pregnancy registry, which we showed the results earlier, but also report any seizures promptly to your doctor. That may trigger a need for another blood level. During labor, deliver an experienced clinical unit that has a pediatric department. Don't deliver in a little community hospital that does not have a pediatrician on staff. If your child, and I think that's true for all women, if you, so I'm not a huge fan of people delivering at home either. If your child gets into trouble, you don't want them on a helicopter. You want someone in that hospital to take care of your child immediately. Also, remember to take your medications during labor. There's a 2% risk of seizures during labor. So some people just forget. Long labors, right? Kate Middleton, her labor less than 3 hours today. Lucky for her, but not everybody has that. What about postpartum? Postpartum, have your levels checked closely. Generally, levels will return to the pre-pregnancy levels within 8 to 12 weeks, but that's not true for Lamictal. Lamictal levels very quickly get very high, and I still feel sorry for the poor women in the early, 1993, 1994, when we started using this drug. Women just thought that postpartum was a terrible time where they were dizzy and double vision and felt like they were drunk. Well, it was really because they required Lamictal increases during pregnancy, and that postpartum, they required a reduction day 1 postpartum. Try to avoid sleep deprivation. That may mean getting help. You may have to have someone else get up in the middle of the night, or family members, but make sleep a priority. and then to discuss breastfeeding. So the American Academy of Neurology and the American College of OBGYN, as well as the American Association of Pediatrics, has recommendations for breastfeeding for women with epilepsy. And the recommendations need to be updated. So let's really talk about probably what we do now. So we know that during breastfeeding that your child will continue to be exposed to an anti-epileptic medication that you're taking, and they'll be getting that through breast milk. What we need to know is how much medication is in breast milk, and that's going to vary for each drug, and that varies based on protein binding. So drugs that are highly protein bound will stay in the bloodstream and they will not enter breast milk. All of the newer drugs have very low protein binding, which is an advantage for other purposes, but what that means is that generally the very high levels will be in breast milk. You also need to know how your child is going to metabolize the medication. So in utero, they were dependent on your liver. Your liver was metabolizing the drug, but they're on their own, and their liver has to metabolize anything that they're getting through breast milk. Here are some of the percentages of medication that's in breast milk compared to mother's blood. So Depakote, not a great drug for pregnancy, happens to be one of the best drugs for nursing because very little Depakote is in breast milk. And you can see that for the newer drugs, very high amounts. So Keppra, 100%. And we don't know about all of the medications, but generally we could predict that it would be high in any of the drugs with very low protein binding. But there is no difference in IQ across the anti-epileptic drugs for women that were breastfeeding or not breastfeeding. In the NEED study, 199 children, 42% breastfed, which is actually a pretty high number. My suggestions for women who are considering breastfeeding is if you want to nurse, go ahead and try it. You can always stop later. It is important to check the level of medication in your child's blood. I always recommend about a day 10 level, and that's done because the first few days of breastfeeding is colostrum. It's not milk, it's the high antibody time. But you want to have your child nursing for at least a week with breast milk before you check a level. When the level comes back from your child's blood, if it's high, then you want to probably either supplement with formula, or you may decide that you're no longer going to nurse. Lamictal is not broken down well by babies. So we did a study of several women who were nursing and on Lamictal. Some of the children had levels that were twice as high as their moms. So you do need caution with that. Keppra and Topamax actually are the opposite. Babies either eliminate them very quickly or they don't absorb those drugs well. So generally, if you check a Keppra or Topamax level on a nursing child, those levels are quite low. Just a word on postpartum depression. 15 to 35% of women with epilepsy will have depression, actually from the first trimester to the 6 months postpartum, compared to 10% of control women. The risk seems to be highest for women that are having a lot of seizures, that also have multiple medications for their seizures, who have a pre-existing mood disorder, or whose pregnancy was unplanned. But treatment is available. So if you are having difficulty with mood, treatment is available. You just need to reach out to people. And I do have some resources listed here, so they're also on. Thank you.
Yes, thank you very much.